for second presentation by Dr. Angelos Kolias, MD, PhD, FRCS, Fellowship of the Royal College of Surgeons. Dr. Angelos Kolias, good evening. In Indonesia, good evening. I think good afternoon in
good evening
in Cambridge. Good evening, Dr. Angelos. How are you?
Salam alaikum.
Waalaikumsalam, Dr. Angelos. I think I go to Cambridge 2 years ago. I met you in there. Thank you so much.
Yeah, with Professor Bajamal. Yeah. Thanks very much for the invitation. Thanks for organizing this meeting.
Yeah, thank you so much, Dr. Angelos. I think this is for you to present your presentation, and yes. I think time and place is your doctors. Please.
So I assume that you can see my screen.
Yes, we can.
Yeah, great. Okay. So I was asked to mention a few research highlights on traumatic brain injury. So, as you said, I work in Cambridge. I'm one of the academic neurosurgeons, and I've worked a lot on global neurotrauma in the last 2 to 3 years. And obviously, this is how I met you and Professor Bajamal. So I think this has already been mentioned, but I think this is a number that we need to remember. So 69 million new cases happening every year worldwide. And you can see that the burden of TBI is mostly in the West Pacific region and also the Southeast Asian region. So in general, we know that low and middle income countries are affected significantly more compared to high income countries. So you can see on the right side of the screen the incidence of TBI from road traffic collisions. And, as Professor Bajamal said, this is no surprising. The other issue is that the resources are very different. And I think, again, Professor Bajamal briefly alluded to this. So on the left, you can see the pre-hospital team that we have in Cambridge, in the East Anglian region. So we actually cover a large area. And patients are often coming from as far as Norwich, 70 to 80 miles away from Cambridge. But there is a pre-hospital team that has also helicopters, and they can go and retrieve patients. And this team consists of anesthetists, so there are people who can intubate at the scene if necessary. Whereas on the right of the screen, you can see, and this is courtesy of Dr. Matthew Joseph from Vellore in India, you can see an ambulance in Tamil Nadu. So the resources are very different. And the problem is that most of the TBI research has been happening in high-income countries. So you can see the DECRA study. I'm sure that most of you are familiar with the studies, the decompressive craniotomy trials. On the left of the screen, you can see the DECRA study, which randomized 155 patients, mostly in Australia and New Zealand. And all of the patients were randomized in high-income countries. Rescue ICP on the right side of the screen is a study that we coordinated from Cambridge, published 4 years ago. And again, you can see that the vast majority, so 91% of the patients were randomized in high-income countries, so only 9% in low and middle-income countries. And this is a problem. And this is what we wanted to address by setting up this global health research group on neurotrauma. And we were actually really fortunate to receive funding from the UK government. The NIHR is the National Institute of Health Research in the UK. And they awarded £120 million overall to fund this type of groups. But about £2 million went to fund the Global Neurotrauma Research Group, and Professor Bajamal and Dr. Teddy are members of this group as well. So this was a group that we launched on the 27th of September 2017, and we're like to have the WFNS as partners, but also the World Federation of Anesthesia, the Royal College of Surgeons. And as I say, the group covers 15 countries. So we have 2 countries in Latin America, Colombia, and Brazil. In Africa, we have Nigeria, Ethiopia, Tanzania, Zambia, Zimbabwe, and South Africa. And then in Asia, we have Pakistan, India, Myanmar, Malaysia, Philippines, and Indonesia. And this is a website for anybody who's interested to take a look. This is a picture from the launch meeting, essentially this is a 3-year project, and actually it has been extended now to a 4th year, and probably it'll be extended more. But the group has been organized around 4 themes. So the research activities cover 4 themes. The first theme is to map the current TBI care provision. Theme 2 aims to understand a bit more in depth exactly how this care is provided. Theme 3 is about innovation in TBI care, and this is subdivided in a few more different themes. And I'll provide some examples later on. And theme 4 is about building research capacity. So how we can empower the participating countries in setting up their own research programs and become centers of excellence in their regions. So as I'll give you some examples now, and this is a very well-known saying, you can't manage what you don't measure. So theme 1, the flagship project is the Global Neurotrauma Registry of the WFNS. So this is called Geo TBI Registry. And this is essentially a web-based registry which will aim to map the pre-hospital, acute in hospital, and also the post-acute care. So we're not just interested in what happens in neurosurgery, as Professor Bajamal alluded to before. What happens pre-hospital is important, but also what happens later on in terms of rehabilitation is important. And the aim of this project is to define the contemporary case mix and also the outcomes of patients globally. And these types of registries, they can be very useful for quality improvement. So, you know, the local participating hospitals, they will be able to download their own data every few months or whenever they want and try and track the patient outcomes in their hospital continuously over time. And this way, for example, if you introduce a new change, for example, you know, if you get a new type of scanner, you know, then you can track the patient outcomes before and after. And then this can be useful for research as well. So this project is now in the pilot phase, and hopefully the global registry is going to launch later on this year. We've been delayed a little bit by the pandemic, but hopefully this is going to launch later on globally. And every neurosurgical unit in the world will be able to participate. But the Vezina study, and I think many of you have come across this study before, but this was the Global Neurotrauma Outcome Study, and this was the first phase of the registry, if you like. So this was a study that was specifically looking at patients having surgical intervention for traumatic brain injury. And we followed them up to 14 days. The study has now closed the recruitment, but this is the number of patients. So we, well, all of us, we collected data on 1,861 patients from 187 hospitals from 57 different countries. And at the moment, we're in the phase of data cleaning, and the analysis will happen shortly after. And you know, I think this is a very good example of the kind of studies that we can do if we work together, if we collaborate together. And these studies are a lot more powerful compared to, you know, perhaps single center studies, retrospective, collecting data on only 20, 30 patients. Moving on to a different example. So moving on to the sub-theme 3B. And these are projects that we think have the potential to help in low and middle income country settings or resource limited settings, where, for example, access to CT is not always easy. So we are looking into non-invasive and potentially cost-effective methods for monitoring brain swelling. And this is a project happening in Ethiopia, Zambia as well. And essentially this is optic nerve sheath diameter. So when there is brain swelling, the optic nerve sheath diameter is going up, it is increasing. And there is some preliminary evidence that this can be useful in terms of monitoring patients when they're in an ICU setting and you don't have, for example, an ISP monitor, and you cannot scan patients regularly. This is moving on to the next sub-theme, which is the sub-theme 3C. This is specifically looking at neurosurgical interventions. And this was the rescue acute subdural hematoma trial. So this was a randomized trial with a randomization happening in the operating room, which is actually really difficult if you think about it, because you operate, you evacuate the clot, and then you have to randomize. And the randomization was to either decompressive craniotomy, so the bone flap is removed or put in the abdominal wall, versus craniotomy. So the bone flap is replaced, but also fixed. So this is not a floating or a hinge craniotomy. It was a fixed craniotomy. And this was adults who need evacuation of an acute subdural. So this study randomized and has now completed the recruitment, 463 patients in several countries. So Australia, Canada, Germany, Hungary, India, Malaysia, Pakistan, Singapore, Spain, UK, and USA. And we had, in terms of sites, collaborating in the global neurotrauma, we had NIMHANS in Bangalore, AIMS in New Delhi, Chandigarh, CMC Vellore, Kuala Lumpur as well, the UMMC, and also the center in Peshawar, the Northwest General Hospital. And the top recruiting site actually was Bangalore in India. And it just goes to show that, actually this type of randomized studies, they can perfectly well happen in resource-limited settings. And as I say, we have now completed the 12-month follow-up, which is the primary outcome measure, and we are cleaning the data. So hopefully we'll have the final results maybe by the end of the year or early next year. And then, again, this was a part of this global neurotrauma project, but in 2017, actually the consensus meeting happened on the same day as the launch meeting. And this was the consensus meeting on decompressive craniotomy, so organized by the WFNS Neurotrauma Committee, AO Neuro, and also the Global Health Research Neurotrauma Group. And the reason we want to have a consensus meeting was, as I said, because DECRA and Rescue ICP mainly randomized patients from high-income countries, whereas we know that the burden of TBI is mostly in LMICs. So we had the meeting organized in small groups. The first group looked at primary craniotomy for mass lesions. The secondary craniotomy group was facilitated by Ivan Timofeev and Jamie Ullman. The third group was looking at surgical technique, facilitated by Tariq Han and David Okonkwo. The fourth group was perioperative care, facilitated by Nina Suket and David Menon. Cranioplasty group was the fifth one, facilitated by Corrado Iacarino and Vicky Warren from Malaysia. And then the final small group was craniectomy in low and middle income countries, facilitated by Tony Figazzi from South Africa and Andres Rubiano from Colombia. And this is the group photograph. And this is the consensus statement. So this is an open access paper published in ACTA. As I say, it is free to access. There is no paywall. And it's remarkable that we had 6,000 downloads in the first 3 months since the publication. And you can look it up on Google, or this is the URL address that you can access it. And as I said, Dr. Teddy and Professor Bajamal were co-authors on this paper, and we thank them very much for their contributions to this very important paper.
Thank you.
And we had 47 statements in total. Do not worry, I'm not going to go through all 47 statements, but I just want to show you the statements about craniectomy in LMICs. So the first statement goes something very obvious that we need to say, however. So we said that the results of DECRA and rescue ICP are not generalizable to the conditions in LMICs, and as such, they cannot necessarily inform clinical practice in these areas. Second statement was that the decisions about craniotomy must be made in the context of local knowledge of the local access to medical resources, capacity for long-term care, and also the cultural beliefs. And then we said that the most craniotomies in low and middle income countries are primary craniotomies. And we also said that we support that because of the limited resources, there are valid indications for craniotomy by the clinical condition of the patient and also the most recent CT scan findings. And then obviously the fourth statement is obvious. The decision to perform a craniotomy should be made by the attending consultant neurosurgeon responsible for the case. But then we did say that when neurosurgeons are not available in exceptional circumstances, adequately trained surgeons may perform a life-saving operation like this. And then the final statement alludes to training the appropriate number of neurosurgeons, which in many countries, there simply isn't enough neurosurgeons to care for all patients with TBI. So moving on, and again, on the back of this consensus meeting, we wanted to develop a further randomized trial. And actually, this was the idea of our collaborators from NIMHANS, Sao Paulo in Brazil, also Pakistan, Ethiopia, and also the group in Colombia led by Andres Rubiano. So I'm not sure if you're using this a lot in your setting, but I have to admit that we don't use Hinds floating craniotomy in the UK a lot. We don't use it in Cambridge. But, you know, this is, the idea is that you evacuate the clot and then the bone flap can be left floating, or you can hinge it with some cranial plates. And there is some evidence, and we have conducted a systematic review, that this might be helpful in terms of providing some ICP control, but its main, and also helping a little bit with brain swelling, but its main benefit would be that the patients do not need to have another operation later on, the cranioplasty, which has costs and also has its own complications that can also set patients back. And as I say, we have now developed a protocol for a randomized study, and hopefully we will find out soon if the study has been funded. And the idea would be to run a large-scale randomized trial in several hospitals and countries. So coming on to the theme 4, which, as I say, this is about building research capacity. And we have already started looking at the mapping of the current neurotrauma research output. But I say we do need to build the research capacity in the participating countries. We have developed a PhD exchange program between Cambridge and the participating countries. We have the collaboration with the BMJ Research Publication Program. So this is an e-learning program that the participating countries can have access for free. It's about simple tasks, which are actually, though, can be quite difficult to perform. So, you know, how to write a paper with clarity, how to apply the protocol. I say it's very this group is the new generation of leaders working in the law, and hopefully this is going to be the new generation. There is a group of research fellows this in Indonesia, in Surabaya. So they're happening in the UK only. So the first one is the DEX chronic subdural hematoma trial. Obviously, this is chronic subdural hematoma. It's not acute TBI, but still it is part of neurotrauma, I think. And this was a randomized trial which looked at a 2-week tapering course of dexamethasone versus placebo for patients with asymptomatic chronic subdural minus the neurosurgical units. Then I will briefly mention about about the MUST trials. So these are 2 trials looking to define best practice in anti-epileptic drugs for patients with a TBI. And then the final one is the REAL trial, which is a single-center pilot trial of early cranioplasty within 3 months after craniotomy versus standard care, so 6 months or more. And I won't say anything more about this study because, as I say, this is a pilot study which is happening in Cambridge, but it is actually recruiting very, very well at the moment. So moving on to the chronic subdural trial, the main question was whether in adult patients with asymptomatic chronic subdural hematoma, a 2-week course of dexamethasone would be beneficial in terms of the course versus placebo. And otherwise, the standard treatment pathway was followed for all patients. So in fact, about 95% of the patients had surgical intervention as well, which is mostly bare hole evacuation with a subdural drain in the UK. So this study has finished recruitment. So we randomized 748 patients from 23 UK neurosurgical units. We had a consultant principal investigator and a trainee associate principal investigator in all units. And also we had support by research nurse in all units. And as I say, the results are very, very interesting. And in fact, we will be submitting the paper for a publication within the next 1 to 2 weeks. I'm afraid that I cannot tell you the results, but they are very, very interesting and they will probably change practice. Moving on to the MUST trial. So these are studies looking at the use of antiepileptics after traumatic brain injury. And we had done a survey in the UK and we had identified 2 areas of uncertainty. The first one is when you have a patient with early post-traumatic seizures, you would normally give them antiepileptics. How long do you continue those antiepileptics for? And our survey had shown that some people, they would stop them when the patients leave the hospital. Others, they continue for 3 months or until they see them in clinic. Others continue for up to 6 months. And others, they continue for a whole year. So this is a question that there is some uncertainty. And the second area is an area that has been previously addressed by randomized trials, the Temkin studies of phenytoin versus placebo. But actually there is still uncertainty. So we want to do a study looking specifically at phenytoin versus levetiracetam versus no prophylaxis following acute TBI. And this will be a study looking at prophylaxis for early post-traumatic seizures. So 2 randomized trials. So they have both been funded by the NIHR. And as I say, these are patients with acute traumatic brain injury admitted to a participating trauma receiving hospital. The 2 studies have slightly different inclusion criteria. So the MUST duration study is looking at patients that have been started on either phenytoin or levetiracetam because of early post-traumatic seizures. And these patients, they come down the left side of the screen. So they are randomized to either up to 3 months duration of treatment or 6 months or more. And then they are followed up for up to 2 years. Coming on to the right side of the screen, this is the MUST prophylaxis trial. So this is specifically looking at seizure prophylaxis. And these are patients who are admitted with acute TBI, and they need to be within the first 2 days of admission to the trauma receiving hospital for randomization to happen. And they're randomized to a 7-day course of phenytoin or 7-day course of levetiracetam or no prophylaxis. And again, they're followed up for 2 years. And I think this is going to be a very interesting study, both of the trials actually. But I say the start has been slightly delayed because of the pandemic. But the plan is to start within this year. And these are the outcomes. So the primary outcome measure for the must duration study is the occurrence of late post-traumatic seizures within 2 years after TBI, whereas the must prophylaxis is the occurrence of post-traumatic seizures within 2 weeks post-TBI. And there are a number of secondary outcome measures looking at functional outcome, neuropsychological symptoms, and also quality of life. So that's the end of my talk, really. Obviously, there are many people that I would like to thank, my colleagues in Cambridge, but also the collaborators in the Global Neurotrauma Research Group based in the countries that I previously mentioned. And once again, I would like to thank the organizers of the meeting, and especially Dr. Teddy and Professor Badzamal for the very kind invitation. Thanks very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Angelos Kolias. It's very interesting presentation. Now, I think Dr. Dito, it is now for the question and answer for our participant, to our speaker and our panelists. I will see in the question and answer test message. There is 2 best question for our speaker, Professor Abdul Hafid Basamal and Dr. Angelos Kolias. I think the first one is from Tamara Audrey. This is for my question is to Dr. Angelos Kolias. The question is the compressive craniotomy necessary to every traumatic brain injury, or are there any criteria for this? And what is the best prime time to do the compressive craniotomy? Thank you, Dr. Angelos Kolias. I think place for answer is your doctor.
Yes, thank you. So this is a very good question. So yes, so the criteria, I think it depends a little bit on the setting where you practice. So the criteria that we have, for example, in the UK and in Cambridge, I'm sure they're very different to the criteria that you would have in Indonesia and also in other resource-limited settings. And just to explain a little bit further, what I mean is that in our unit, we have ISP monitoring, and also, in fact, we have multimodality monitoring with brain tissue oxygen monitoring, with microdials monitoring. And also, we have a mobile scanner. So when we want to get a new CT on a patient, it's very easy to do so. There is no concern about moving the patient to a different place, whilst they're intubated, etc. So that makes a big difference, because that means that we can manage the patients medically, control the ICP, and in those patients, often there is no need to proceed to a craniotomy because you can manage the ICP medically, and many of them, they do not eventually proceed to needing a craniotomy. Now, this is for patients with perhaps contusions, diffuse type injury, that they do not have a discrete mass lesion. If they have a discrete mass lesion, it is slightly different. So if you have a mass lesion like an acute subdural that needs to be evacuated, then a craniotomy is an option. It depends a little bit on the circumstances of the specific patient. So it depends on whether they have significant parenchymal injury, loss of contusions. It depends on their pupillary status as well. It depends on the state of the brain as you evacuate the subdural. What does the brain look like? Is it very swollen? Is it very swollen, or is it very relaxed? But specifically for this question, the rescue acute subdural trial, I think, is going to be very as to whether we should be craniotomy. Now, in terms of the resource-limited settings, as I said, the criteria are going to be different, because we know that access to ISP monitoring is not always available, and in fact, in many countries, there isn't any access to ISP monitoring. Getting repeat CT scans is difficult, so we know that there is a lot more utilization of decompressive craniotomy up front, simply to prevent any secondary deterioration or secondary insults. So I'm afraid that it is a difficult question to answer because of the reasons that I mentioned. But if you want to look up the consensus statement, I'm hoping that you can get some ideas about the more specific indications on craniotomy for TBI.
Thank you, Dr. Angelos Kolias. I will explain to bahasa. I'm sorry. I will explain to bahasa to for Tamara. Jadi untuk kasus kapankah waktu terbaik kita melakukan dekompresi craniotomy itu sangat berbeda di antara negara maju dan negara yang tidak maju. Untuk di daerah Cambridge, misal di Eropa, memang mereka memiliki semacam ICP monitor parenkimal dan tisu oksigenasi monitoring, sehingga mereka lebih mengutamakan penanganan ICP tekanan intrakranial di ICU yang pertama. Jadi terapi definitif dulu dengan pembelian semacam obat-obatan dan segalanya untuk menurunkan TIK. Jadi tidak selalu harus menuju ke operasi dengan melakukan dekompresi craniotomy. Jika penanganan terapi di ICU dengan segala macam obat yang kita telah berikan ternyata tidak membaik, maka dan tanda-tanda TIK masih bisa meningkat, maka kemungkinan besar yang terakhir kita bisa melakukan tindakan dekompresi craniotomy. Jadi dekompresi craniotomy adalah sesuatu yang tidak harus kita lakukan. Itu jawaban untuk Tamara Audrey. Sekarang untuk tambahan jawaban akan saya lempar ke panelis, mungkin yang belum Dr. Wihasto, nggih. Dr. Wihasto, mengenai pertanyaan dari Tamara Audrey, apakah ada sedikit masukan untuk kami, Dr. Wihasto? Terima kasih banyak. Dr. Wihasto, nggih.
Mohon maaf kena mute. Terima kasih Dr. Teddy. Jadi terkait pertanyaan yang tadi memang saya rasa sudah jelas ya bahwa kapan kita melakukan dekompresif craniotomy atau enggak, itu karena kita sudah ada algoritma tier-tier, artinya langkah-langkah bagaimana cara mengatasi tekanan intrakranial yang tinggi pada traumatic brain injury. Jadi yang dijelaskan oleh Dr. Angelos Kolias tadi saya rasa mestinya sudah jelas dan lebih diperjelas lagi oleh Dr. Teddy. Dan memang pada usia-usia ekstrim, artinya pada anak-anak dan pada geriatri, mungkin dekompresif craniotomy ini menjadi suatu dilema tertentu karena pada anak-anak itu otaknya sangat gampang sekali menjadi ödem, sehingga dengan kondisi brain injury tertentu, maka kita memutuskan walaupun mungkin SDH-nya itu tipis, kurang dari setengah senti, tapi melihat ödemnya dan kemudian midline shift-nya dari CT scan, mungkin kita memutuskan untuk dilakukan dekompresif craniotomy sebagai salah satu pilihan. Tapi pada orang tua yang seringkali otaknya mengalami brain atrophy, walaupun dengan perdarahan yang cukup besar, saya rasa terkadang malah dekompresif craniotomy itu lebih tidak memberikan hasil yang lebih baik daripada ketika tulangnya tidak di craniotomy. Ini pada kasus surgery ya. Tapi tidak semua traumatic brain injury akan end up with dekompresif craniotomy, no. So traumatic brain injury has several types of morphological injury. So dekompresif craniotomy is not always an indication for traumatic brain injury. I think I hope that can answer to Dr. Tamara Audrey.
Thank you. I think one more question, Dr. Angelos Kolias. One more question from participant Dr. Umi Kulsum. Good evening, Professor Angelos. I want to ask, is there any golden period to do surgical intervention for traumatic brain injury? And I have heard if the hemorrhage is minimal, below 25 cc from the CT scan, it is not considered to undergo surgery. I think the answer is, I think the question is there any golden period to do surgical intervention for traumatic brain injury?
Yeah, so this is a good question, and I think, again, the answer is that it depends on the indication. So it's difficult to give a specific answer, Obviously, there is the 4-hour golden rule from a paper published quite a few years ago, actually, in the New England Journal of Medicine, specifically looking at craniotomy for acute subdurals, and it had found a difference in outcome. So, you know, people often use this sort of 4-hour rule. But I think, you know, in general, we would accept that if somebody has anisocoria, has a scan which shows significant midline shift, significant mass effect, and has a large subdural, the sooner you can get them to the operating theater, assuming that they have been stabilized and there are no other extracranial problems, you know, like, for example, a splenic injury or a liver injury, and the patient is hypotensive. So assuming that the patient is stable and there are no other problems, the sooner you can get them to the operating theater, this specific patient, the better it will be. There is no doubt. You have somebody who is anisocoric, in coma, with a large subdural with mass effect. On the other hand, if you have somebody, for example, who has a GCS which is, you know, about 13, 14, with a size subdural, with midline shift which is perhaps, you know, 5 to 6 millimeters, and the mechanism of injury was a simple fall from standing, and you know, the patient is, you know, as we often see these kind of patients here, you know, in their 70s on aspirin and or clopidogrel, you may even elect to initially observe, because, you know, as they're on 2 antiplatelet drugs, operating would be quite high risk. And obviously, if the patient deteriorates, then you might decide to operate with some platelet cover. So you give them platelets as well to counteract the effect of the blood thinning medications. So it depends a little bit on what the exact context is. You know, patients that we medically manage in the ICU, they can still do well, and the rescue ICP study showed that this is an acceptable practice. So using a craniotomy as a last resort therapy in this setting. So yeah, I'm afraid that there isn't a specific number that I can give, because it depends on the context very much.
Thank you, Dr. Angelos. I will explain with bahasa to Dr. Jadi pada kasus kapan golden period yang terbaik, menurut Dr. Angelos Kolias, beliau tidak mempunyai waktu yang tepat dan tidak bisa memberikan menit maupun jam yang baik, akan tetapi semua bergantung dari indikasi kapan memang harus dilakukan tindakan operasi. Bila salah satunya ada pemberian obat-obatan seperti antiplatelet dan kemungkinan semacam clopidogrel telah diberikan, maka kita harus melihat apakah ini harus segera dilakukan tindakan operasi apa tidak. Karena dengan pemberian antiplatelet, maka kita akan memiliki resiko yang lebih tinggi untuk terjadinya hal-hal yang tidak kita inginkan. Jadi kita kembali lagi ke awal, Dr. Angelos Kolias tidak dapat memberikan waktu yang tepat. Akan tetapi Anda harus melihat tetap indikasi yang bisa kita lakukan untuk pasien ini. Mungkin satu lagi dari panelis yang bisa membantu saya dalam memberi jawaban, Dr. Farid mungkin, atau Dr. Hanif.
Okay, thank you very much. So I agree with Dr. Kolias, because it's really depend on the resources that we have in our center. Most of in a very good pre-hospital management to bring the patient right into the center. So usually they call it as a golden period is 3 or 4 hours. But in my center in Bandung, it seems difficult because of many obstacles, traffic, whatsoever. So we call it as a golden period when we can doing the intervention is in between 6 or 8 hours. So it's really depend on the resources, and I really interesting to doing this kind of research with your center if it's possible, because we don't have data for this, and if we have data and we have many cases, I mean, it really can become our protocol, and it's very interesting to see what the result is. Thank you.
Thank you, Dr. Farid. Mungkin untuk Dr. Hanif, akan dapat memberi
Ya, ini
masukan.
tadi pertanyaan pakai bahasa Indonesia bisa ya?
Iya.
Tadi pertanyaannya kan mengenai golden period ya.
Iya, Dokter.
Sebenarnya itu sih kalau kami di RSCM ya, kita emang pre-hospital tuh belum bisa diandalkan. Ya kalau kita golden period yang dipegang malah ya mungkin nggak ada tindakan lagi ya kan. Jadi waktu masuk itu kita nilai tuh, kita ada kriteria gitu untuk dekompresi itu ya, misalnya termasuk salah satunya keadaan Glasgow Coma Scale. Kalau memang Glasgow Coma Scale-nya rendah ya mungkin kita udah lebih banyak untuk memberikan konservatif terapi ya dengan pemberian obat-obatan. Siapa tahu Glasgow Coma Scale bisa naik. Gitu. Ya biasanya kebanyakan sih 8 begitu ya. Kalau dari bawah itu memang apalagi dengan era BPJS tuh nanti dipertanyakan tuh pasiennya kenapa lo bangun gitu ya. Jadi kita juga banyak komplikasi yang lain gitu yang harus kita pikirkan, nggak cuma hanya sekedar indikasi dan teknik operasi begitu. Jadi kalau menurut saya dalam melakukan suatu dekompresi pada saat ini mah yang penting waktu masuk rumah sakit itu GCS-nya berapa begitu. Kalau misalnya kriteria untuk dekompresi itu bisa dikerjakan, masih memasuki kriteria ya kita kerjakan begitu. Walaupun 1-2 jam misalnya dia datang tapi dia GCS sudah 3 kan kita nggak lakukan dekompresi juga gitu kira-kira. Terima kasih.
Ya, terima kasih Dr. Hanif untuk masukannya. I think because of our limited time, this is the end of our first session. Thank you, Dr. Angelos Kolias, for your interesting presentation.